Our next speaker is Dr. Arwa Ali. Dr. Arwa is a former colleague in Sheffield Orman Hospital, and she is now a scholarship master student in International University of Japan, Niigata, Japan. The case will be entitled Blue Out of the Blue. Dr. Arwa, are you with us?
Yes. Can you hear me? Is it done now?
Yes, great. Press hide for the bar that appears below, and then go on.
Thank you. Okay, thank you. The case title is Blue Out of the Blue. This might sound too obvious to some or too confusing to others. For me, I think it perfectly captures what happened in this case. Hello, I'm Dr. Arwa Ali. I am a former pathology registrar at Sheffield Orman Oncology Hospital. I am now a scholarship student doing master's in business administration in Japan. My supervisor is Dr. Muhammad Hussein. He is a consultant histopathology and Sheffield Children's NHS Trust, and Rotherham NHS Foundation Trust in the UK. Without further ado, I'm going to start discussing my case by going for the history. This is a case of a patient who is 40 years old, male, heavy smoker. He was presented to Sheffield Orman Oncology Hospital with CBC showing normal hemoglobin with with elevated white blood cell count of 27, showing absolute lymphocytes of 85%. On physical examination, we found that he had multiple enlarged bilateral submandibular lymph nodes, left enlarged inguinal lymph nodes, associated B symptoms, but there was no hepatosplenomegaly. For further lab workup, the flu cytometry was done. It showed positivity to CD19, 5, 20, 22, and 23, which is consistent with mature B cell population with kappa light chain restriction. For radiology, chest CT showed that the patient had enlarged mediastinal hilar axillary lymph nodes, subpleural pulmonary nodules, and mild splenomegaly. Given all of these data, the patient was diagnosed as having chronic lymphocytic leukemia and was put on follow-up every 3 months. 6 years after close follow-up, after 6 years of close follow-up, the patient came to the hospital complaining of right gluteal abscess and enlarged right gluteal lymph node with skin edema and induration. The patient's CBC at that time showed lower hemoglobin than before with elevated white blood cells. It was 27 before, now it's 122, still lymphocytosis. And this time we had LDH markedly elevated of 995. And his chest CT this time shows generalized lymphadenopathy and progression of the subpleural pulmonary nodules, with conclusion of markedly progressive course regarding size and numbers of lymph nodes, with newly developed right inguinal intramuscular and subcutaneous lymph nodes. The size of the largest was 9.2 by 4.5 centimeters. The patient was sent for biopsy from the right inguinal lymph node. Starting now, we're going to talk about the histopathological examination. We will start by the low power. The low power shows a core of lymph node with a phased architecture that is infiltrated by sheets of blue round cell. Moving to the high power to appreciate these cells, the cells are of intermediate to large size with hyperchromatic nuclei. There is no prominent nuclei, and there is scanty cytoplasm. And these cells are quite discohesive. So our diagnosis at that time was this could be a transformation of CLL into diffuse large B-cell lymphoma, which is known as Richter's transformation. So we had ruled out. For this, we ordered this immunohistochemistry panel, CD20, 5Ki, and PAX5. We're starting by CD20. As we can see, the low power on the left and the high power on the right. CD20 is negative. Moving the CD5, the same, it is negative. Ki 67, we found out it is positive in about 80% of the cells. PAX5 also came back positive. And our conclusion at that time was this is a diffuse large B-cell lymphoma transformation. So we ordered LCA and CD23 to support our initial diagnosis. LCA came back negative. CD23 also came back negative. Now, what are we dealing with? Is this diffuse large B-cell lymphoma with apparent phenotype, or is it like another tumor? So to know what we are dealing with, we ordered cytokeratin and CD79A. Cytokeratin on the left came back diffuse strong positive, and CD79A on the right came back negative. At this point, we were like, where should we go? Should we follow the pan-cytokeratin, the positivity for pan-cytokeratin, or the PAX5? Which should we trust? So we decided to go with more epithelial markers. We went for CDX2. It came back negative, excluding metastatic gastrointestinal carcinoma. GATA3 also came back negative. It's not metastatic urinary carcinoma. TTF1, because the patient had the pleural nodules, the lung nodules, and it also came back negative. So we did S100 and SOX10, also came back negative. At this point, the only thing we had positive was synaptophysin. It came back weak positive. So we tried to support it with chromogranin, and it also came back positive. CD56 came back positive. So now we have 3 neuroendocrine markers that are positive. So this led us to this case being metastatic neuroendocrine carcinoma. So we decided to know, where did this come from? Where is the origin of this tumor? So we went for CK7 and CK20. Cytokeratin 7 on the left is negative, and cytokeratin 20 on the right came back diffuse strong positive. So we ordered SAD-B2. It also came back positive. So now we have a diagnosis finally. We diagnosed it as metastatic neuroendocrine carcinoma of colorectal cancer, of colorectal origin. But sadly, we did not find anything that support that. We did not find any radiological or endoscopic findings to support the presence of this kind of tumor. So now we need a recap. This is a case of a patient with history of CLL that came now complaining of enlarged inguinal lymph node, right inguinal lymph node, and the biopsy from that lymph node is positive to PAX5, neuroendocrine markers, cytokeratin, pan-cytokeratin, cytokeratin 20, and SAD-B2. What is that? So what if you were in our shoes, what kind of question would you ask the clinician? Where would you ask him to look? In our case, we contacted the clinician and we asked him, do you happen to find any skin ulcer in this patient anywhere, maybe like in his leg, maybe on the same side, the right leg? And the clinician was, yes, this patient has actually a skin ulcer in his leg and it's non-healing. So now we have a patient with tumor that is positive to PAX5, neuroendocrine tumors, pan-cytokeratin, cytokeratin 20, SAD-B2. Also, he has leg ulcer. Now we have a diagnosis. It is metastatic Merkel cell carcinoma. So as you can see, again, back to the H&E, we can see the lymphocytes here, and we can see the infiltration by the Merkel cell tumor. Here again, the lower power, we can see the large cell of Merkel cell and the lymphocytes, but this is a blue. But what does it mean, blue out of the blue? Actually, he had metastatic Merkel cell carcinoma, but it is in a lymph node involved by CLL. And to understand that, we have to look back at the immunohistochemistry interpretation that we did before. We had cytokeratin, it was diffuse strong positive. That's true, that's a true interpretation, but LCA was also positive in the intervening lymph node, which makes sense, this is a lymph node. But we also had CD20 positive in the lymphocytes, with co-expression of CD23 in the same lymphocytes and CD5 in the same lymphocytes. And we also had PAX5 positive in both population with more intensity on the lymphocytes. This makes it more in favor of infiltration of two population, the CLL and the metastatic Merkel cell carcinoma, as I've said earlier. Moving on, what is CLL? It is a small round B-cell tumor in the peripheral blood, bone marrow, lymph node, and spleen. It has a characteristic immunophenotype of CD23 and CD5 co-expression. It's usually presented by generalized lymphadenopathy in people over the age of 50, mostly asymptomatic. Even if the patient was diagnosed, they would be put on follow-up without treatment. But if there were to be a Richter transformation to diffuse large B-cell lymphoma, in this case, we need to go for aggressive treatment. CLL also has a high risk of developing second cancers, like gastrointestinal cancer, breast, lung, prostate, and in our case, Merkel cell carcinoma. About Merkel cell, it is a rare aggressive type of cancer, skin cancer, that spreads to lymph nodes and other organs. The cells are type of neuroendocrine cell that has both nervous system and endocrine system function. We had the excision of that skin ulcer, and now we have a confirmation of our primary diagnosis, and this is the same.
بقول لك يا ام هشام، انت تعرفي حته نسبق فيها؟ نعمل ايه؟
Please, colleagues, turn off your mics. Dr. Arwa, we can't hear you. Dr. Arwa, please unmute yourself.
Is it okay now?
Yes, okay. You can get back to slides and continue.
Which slides?
2 slides from the current slide back and continue.
This one? Okay. About the immunophenotyping of Merkel cell carcinoma, the neuroendocrine markers are usually positive, with cytokeratin and cytokeratin 20 positive in adult-like pattern. PAX5 and SADB2 are positive in 80% of the case, TDT in 50% of the case. There's a characteristic marker for Merkel cell carcinoma, which is Merkel cell polyoma virus in 85% of the cases. And the cases who are not positive to it are positive to P63. So my take-home message is we have to know about Merkel cell carcinoma and its characteristic phenotyping, and the possibility of double malignancy that comes with chronic lymphocytic leukemia. And also, we have to always be aware of the apparent immunohistochemistry expression and always suspect the incomplete immunophenotyping. And the final one is clinical, radiological, and pathological integration of all of the data is always mandatory. So I'd like to thank you all for this opportunity to speak and share this interesting case with you. This was the photo from last year's presentation, International Pathology Day. Thank you, Dr. Muhammad Kamal, and thank you, Dr. Amira, for making this event repeat itself again this year. Thank you, Dr. Muhammad Hussein, for being my mentor and supervisor in this case. Dr. Angie, I miss you a lot. My daughters in pathology, Dr. Dina and Mario, I love you. I miss you guys a lot. And finally, Free Palestine. Thank you.
Thank you so much, Dr. Arwa. Such an interesting case.